Good afternoon, everyone, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we'll be discussing strategies for rehospitalization reduction. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. And you can also raise your hand to request to be unmuted to ask your question out loud during the discussion period. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is gearing up for fall immunizations. And that webinar will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again.
Thanks, Kathy. So today we're going to be talking about some basic strategies to reduce rehospitalizations. And we're primarily going to be talking about our skilled or short-term residents, though a lot of these strategies can be applied to all of our residents. And a lot of the strategies not only reduce rehospitalizations, but they can actually improve quality of life for a lot of our residents and hopefully extend their life. So how I like to think about this as being a medical director and attending physician who's taken care of residents in nursing homes for a long time, that there are very simple things that we can do that may not seem that they're going to make a big difference, but they can make a big difference. So we're going to talk about why we should reduce rehospitalizations. And I will say, I think the climate in long-term care is that if we need to send a resident out, we should just send them out. Why should we just try to keep them in the building? So I'm going to talk about recent data research that has indicated that our residents actually do better if we treat them in place, if at all possible, even for significant events that appear on the surface. The resident should go to the hospital. These residents actually do better. Mortality is lower if we treat them in place in the facilities. We're going to talk about the big areas of cause of hospitalizations, sepsis being one. We're going to talk about advanced care planning and how we can utilize advanced care planning to reduce rehospitalizations and hospitalizations. We're going to touch a little bit on falls and some prevention opportunities. And then we're going to talk about medication management for red flags. So this is an initiative that was started by CMS. CMS is very interested in figuring out, can nursing homes reduce hospitalizations? So they're undergoing this initiative. I think that this is something that we should be paying attention to, because CMS wants to understand what residents are being hospitalized, why residents are being hospitalized, what residents are being hospitalized, and what are the outcomes for residents who are hospitalized versus residents who are treated in place. So in this study, it was a CMS initiative, residents treated on site in the nursing home were directly compared to residents treated in the hospital for one of 6 conditions. So the results I found very surprising, and I think everyone should probably find it surprising, that residents treated initially in the hospital were about twice as likely to be subsequently treated in the hospital. So if they're treated in the hospital, they're probably going to go back, twice as likely that they're going to go back. And they're more than twice as likely to die, 17% versus 7.8%. So we know that if we initially treat residents in place, they have a lower mortality. So I think that this is something that CMS is going to be paying very close attention to, because this isn't just about cost. Yes, Hospitalizations are more costly for CMS. Hospitalizations are more costly for everyone. But residents who get sent out to the hospital versus residents that get treated in place, the residents who get sent out to the hospital actually have a lower life expectancy. They're more likely to die. So this is something that we have to take very seriously. The results indicate that there's a possible benefit for treating residents on site. This study is ongoing. So this is something that we will probably hear more about in the coming year or so. So the top diagnoses for hospitalizations from nursing home, according to the Office of Inspector General: sepsis, COPD, and asthma, pneumonia, congestive heart failure, urinary tract infections, dehydration. So I'm sure you all know about these, but these are the diagnoses that were looked at in that study. So I were going to be focused on reducing hospitalization, I would be looking at these diagnoses. So when I think about reducing hospitalizations, I think about low-hanging fruit. I think about things that we can do simply, very simple, basic steps that we can take. I think about sepsis prevention. I think about falls prevention. I think about advanced care planning. And I think about medication management. So sepsis is the big one, and that's what we're going to talk about first. Sepsis is going to cause a lot of hospitalization. It causes a lot of hospitalization. We're going to talk about falls. A lot of residents get sent out because of injuries. Even if they're DNI, DNR, do not hospitalize, residents will get sent out to the hospital if they fall. Advanced care planning. There are many residents that it's not actually very clear if they do want to be hospitalized or not, and it's not discussed or talked about. And then these residents get sent out to the hospital, even if they don't want to go to the hospital. And then medication management. We know that adverse drug events contribute to hospitalizations. So we're going to talk about some medications that you can take a look at and potentially deprescribe and then reduce risk of hospitalization. So we're first going to talk about sepsis prevention. I love this quote: illness has a lot to teach wellness. So what is sepsis? Just a basic review. It's the body's extreme response to an infection. The infection that causes sepsis starts prior to a patient going to the hospital most of the time. This is why we can get ahead of it. 1 in 3 people who die in the hospital have sepsis during the hospitalization. We know who's at risk. It's our residents greater than 65, chronically ill, young children as well, immunosuppressed, individuals who previously had sepsis, and I'm sure you can probably look at all of your residents and say most of them were previously diagnosed as having sepsis, people who have a recent severe illness or hospitalization. So most of our residents are at risk of sepsis. So nursing home residents are 7 times more likely to have severe sepsis. They're more likely to be admitted to the ICU. They have longer hospital stays associated with sepsis. They have higher mortality rates, and they're more susceptible to adverse effects of the hospitalization, like delirium, other infections. That's why we have to be very careful and make sure that we have a protocol in place to get ahead of sepsis so we can discover it early, treat in place, and reduce the likelihood of mortality in our residents. So can we prevent sepsis in the nursing home? We can. I've seen it happen. I've done it many times. But because symptoms and signs are nonspecific in older adults, especially in our residents, especially with individuals of cognitive impairment, as this quote says, any change in condition could represent early sepsis due to infection in our residents. That's why we have to get ahead of things. We have to have tools to detect what's happening early. So this was a study that was undertaken with 31 community nursing homes in North Carolina. The mean bed size was 113. So the licensed nurses and CNAs were staffed at an average rate of 1.5 and 2.2 hours respectively per resident. And the mean quality rating on nursing home compare for the nursing homes was 3.3. The nursing homes did not differ from all nursing homes across the country. So they did a study looking at if it were possible to detect early sepsis in nursing home residents to prevent them from being sent to the hospital. And all 4 vital signs were documented during the 12 hours prior to hospitalization in only 66% of the sepsis cases. So, and for 13 to 72 hours prior to hospitalization, all 4 vital signs were documented in 73% of the sepsis cases. So this is telling us that vital signs were not something that were universally taken in all of the cases of the individuals with sepsis. This is telling me that if we see a change in condition in a resident, that should be brought to the attention of all individuals involved in the resident's care, and vital signs should be taken, because any change in condition in a resident who has advanced dementia, other cognitive impairment, comorbidities, any change in condition could represent early sepsis. So that's why it's really important to get vital signs if we think that something is not quite right. Another thing, documentation of a visit by a medical provider in the 12 hours prior to hospital transfer was present in only 19% of the sepsis cases. So very few residents were seen by a medical provider prior to being sent out to the hospital when they had a diagnosis of sepsis. So that's something that really needs to improve. I get it. It's very difficult to get physicians to see residents in the nursing homes, but we really need to hold our medical providers accountable, because we can save lives if a resident is seen by a medical provider if there's a change in condition. So the learning points of the study were that the sepsis tool that was shown to be most sensitive was the 100, 100, 100, as well as oral temperature greater than 99. So this is telling us that it's essential to obtain and document vital signs as well as any changes in cognitive status. It's important to engage the provider early, to tell the provider something's not quite right. We obtained our vital signs. Is their temperature above 100? Is their systolic blood pressure below 100? Is their pulse rate above 100? If any of those things are happening, it's essential to engage the provider, let them know, I feel that this could be early sepsis. Is there any interventions that we can get started to treat the resident in place? Because that is going to save their life. That is going to save their life more than sending them to the hospital. So that's something that we can have power over. So there's a ton of early warning tools. This one is easy to use. It's through the Interact system. Interact has done a lot of work in rehospitalization reduction. I would encourage you to download it, or just, you can Google rehospitalization or SBAR tools and use any one that you would like, but it needs to be used universally. So it's really important in sepsis to educate staff to recognize and respond early. This is the opportunity to empower staff to impact outcomes. And when we do empower staff, we actually improve staffing stability. So something to keep in mind, CNA leadership opportunity. Perhaps you have a sepsis team, you have a leader of the sepsis team, and that team gets initiated, gets activated when there's a change in condition. Vital signs are taken, then an entire assessment is done, provider is called, and you can really impact outcomes. And when you engage and empower individuals, staff in that way, you can actually improve your staffing stability. It's important to contact the provider early whenever you suspect a change in condition, and hold the medical director or attending physician accountable for being available. Lab studies should be ordered early, at least the basics if you can't do a lactate or procalcitonin. Ensuring IV hydration, getting that started early is the cornerstone of sepsis management. Always started early. If we suspect sepsis, we get the line started. That should be the very first thing that should be started. And then antibiotics should be initiated early, preferably within the first hour of sepsis recognition. And then contact the provider early. These are things that can definitively save lives if we get the process started in our facilities. Falls prevention. So I've been involved in falls management for a very long time. I will say it is very challenging work. And I think it's very challenging work because it is such an individual process in order to determine why each resident is falling. It's not like something that we can apply blanket wide in the facility. We can do a lot of falls screening. We can have a falls process in place, but really we need to look at each individual resident to develop a tailorized plan in order to reduce falls. So when I think about 5 areas of fall risk, I think about medications. We know there are certain medications that definitively increase fall risk: antidepressants, antipsychotics, benzodiazepine, anticholinergics. So we need to look at the individual's medication. Anytime an individual falls, we need to look at their medications, and we need to determine if there are any on their list that could potentially cause falls. And then if you're not sure, you can always engage your pharmacist to take a look and make sure there's no medications that might be leading to, that could be potentially a cause of falls. Orthostatic hypotension, another big area. Postural vital signs should be checked as appropriate. Orthostatic hypotension is fairly common in older adults, so this should be on the radar always. Vision. Make sure we're observing the resident during activities of daily living for signs of poor vision, tripping, difficulty finding object, detecting changes, floor surfaces, and then obtain a suitable consult as needed for improving vision, glasses, that kind of thing. Mobility. Always important to make sure we're screening our residents for safety issues, gait, balance, and transfers. Getting our physical therapy colleagues involved to help us out for reduction of falls. And then unsafe behavior. Always important to be able to screen residents for unsafe transfers and ambulation, and making sure that we know if these residents are unsafe and we're utilizing tactics in order to make them more safe. So interim plan of care, close observation and increased supervision. I'm sure you all know this. Frequent orientation to room, bathroom, and facility. I think this is really important. And I say, when I go in and see residents, I often will do this. And I think people might think that I look silly, but I think it's really important to continue to let the resident know your bathroom is here, this is your side table, your wheelchair is here, what facility they are in. These frequent orientation exercises can really improve the resident's ability to figure out how to ambulate around their room. Medication review should be done with every single fall. Use of safe footwear, making sure that the resident's footwear is appropriate. Staff assistant to toilet or bedside commode. I know this is a difficult thing. I don't know how many times I have heard when a resident is on the floor, why didn't you call? Why didn't you ring your bell? I know it's very challenging, but that's an obvious. Use of monitoring or sensor devices as needed and appropriate, and use of pressure position or other alarms as needed or appropriate. I think the frequent orientation to room, bathroom, and facility is something that is really underrated. Like, it's something that can make a big difference that we don't often do. And then use of protective clothing devices as needed. This is a fall intervention plan that you can download from the Agency or Healthcare Research and Quality. They actually have a really extensive toolkit for fall management. If you want to really get into you're very committed to reducing falls in your facility. I think that it looks just fantastic, but this is one of their fall intervention plan that you can utilize, and you can see that it's broken down into medication, orthostatic hypotension, vision, unsafe behavior, and mobility. And then you have selected interventions under each category. And you can utilize that intervention like a copy project and then assess. Utilize one intervention, see if you have a reduction in falls. If it doesn't work, you abandon that intervention, you try another intervention. But this just gives you a really great way. You can write the resident's name on top and then do your intervention and keep track of what interventions you do. Advanced care planning. Big one. And I think that this is one that we forget often in long-term care, and it really is an art. I just wanted to bring up the federal regulation that it is required for advance directives. The resident should be informed for their right to accept or refuse medical or surgical treatment. It is their right to formulate an advance directive. It's got to be written in the facility's policies. Facilities are permitted to contract with other entities. If the individual is not able to formulate an advance directive themselves or have the conversation, then the facility may give the advance directive information to the individual's resident representative according to state law. So follow-up needs to be done. This is in the federal regulations. So if a resident has a change in status, something big happens, we need to follow up. We don't just go with the initial do not resuscitate initial plan in the advance directive. If there's a change, we have to go back. We have to talk to the resident, talk to the family and say, there's been a change. This is what's going on. You know, what would you like to do? But hopefully have the physician, nurse practitioner, PA, explain things to the resident and family. Hospitalization at the end of life, especially for nursing home residents, is really significant. 25.5 to 69.7 of residents at the end of their life are hospitalized. There are some residents, and there's some of us that want to be hospitalized at the end of their life, but there are many who do not want to be hospitalized at the end of their life. This is why we have to do a really good job of ensuring that we know what a resident's wishes are, and those wishes are respected and carried out. So the advanced care planning helps residents understand what is going on, and then they can communicate their wishes regarding their end-of-life care. Advanced care planning interventions have been shown to reduce hospitalizations of nursing home residents. There's a lot of nursing home residents that don't understand they don't need to go to the hospital. They can choose not to. They can choose to be treated in place. So there's a big difference between just saying, I don't want anything, and I want to be treated in place in the nursing facility. And I think that a lot of people don't understand that. And quite honestly, the research that I shared in the beginning is showing us that the individuals that actually get treated in place in the nursing home are actually going to have a improved mortality versus going to the hospital. This is why we have to be very clear to talk to our residents about what the data says, and then talk to them about what they want, what their wishes are. Advanced care planning is most effective when it's done within 7 days of admission or readmission. Every time a resident is admitted or readmitted, it needs to be done. When more information is needed, resident doesn't understand hospice, doesn't understand what palliative care, then another advanced care planning visit needs to be done. A conversation needs to be had. Also, when there's a major health status change, it needs to be done. We need to bring it up again. So that's when advanced care planning is most effective. So some recommendations to reduce unwanted transfer. Discuss transfer to hospital wishes before a health crisis occurs, as well as the hospitalization impact on the resident. It is not benign. Hospitalizations take a lot out of our residents and actually decrease their life, decrease the length of their life. So that needs to be discussed. Always document preferences for hospital transfer in the setting of an acute medical illness. What's really important and what's really coming out in the research now is that there are some residents who do not resuscitate, do not intubate, do not hospitalize, but they have an injury and they get sent out to the hospital. So it's really helpful to have a conversation and say, if you have a fall and you have a fracture, Do you want to go to the hospital? I will say I have had talked to residents both ways. I've had a resident with a femur fracture who did not want to be sent out to the hospital and successfully treated the resident in place, talking to an orthopedic surgeon extensively, getting x-rays in the facility, and the resident actually nothing, we treated successfully in the facility. So we can do these things in the setting of an acute injury treat in place, but we have to make sure that we have a long conversation with the resident about risks, benefits, all of these things. We also have to make sure we have clear plans for residents with complex medical issues or palliative care. A resident might say, I don't want to go to the hospital, but if my life is coming to an end, I want to be comfortable. And we can ensure that our residents that we have as needed medication on board. And then we make sure that all members of the care plan, all the resident, the decision makers, all understand what is going to happen prior to a health crisis occurring. We don't want our resident to go unresponsive. They've made a decision, and then a nephew from out of state calls and says, send them to the hospital. That's what I want. We have to make sure that doesn't happen. So we respect the wishes of the resident. There's so many decision aids online. Again, this is available for download, and it's exceedingly helpful. So last but not least, we're going to be talking about medication management. And I think we all know this, medicine sometimes snatches away health, sometimes gives it, right? It really depends on the individual. So some potentially inappropriate medications shown to lead to hospitalizations: opioids, benzodiazepines, diabetic medications, sliding scale sulfonylureas. Sliding scale I know is used widely in nursing home residents. Really not appropriate according to guidelines. Anticoagulants, warfarin, DOACs. These have led to hospitalizations. Anticholinergics like oxybutynin cause falls. Antipsychotics increase risk of hospitalization. Diphenhydramine, we have a lot of residents on diphenhydramine and hydroxyzine. I will say, if there are just two medications that you can reduce in your resident population, it would be those two, diphenhydramine and hydroxyzine, just not appropriate for use. Potentially, if you're going to use them at all, that they should be very, very short term. So this is a link to 10 medications that we should avoid using in older adults. I would encourage you to look at the Beers list, which is a list of medications that is inappropriate in older adults, and show it to your providers. This download is actually a poster that can be placed in your facility, and I would place it in line of residents, families, visitors. They can ask questions and then they can know. Any questions? I know we shared a lot of information today.
All right. So if anyone has any questions, please submit it using the chat or the Q&A tool in your Zoom menu, or you can raise your hand to request to be unmuted to ask your question out loud. I put links in the chat for both of those, for the flyer that was just on the screen, as well as that registration page if you're interested in attending that webinar series, or just certain webinars inside of that series. While we are waiting, I'd like to again invite everyone to next week's webinar, which will be about gearing up for fall immunizations. So that will be the same time and place next week, Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright or one of our other quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to those live chats in our webinars, in the newsletter that we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org, and I will get you on that list. And now I will put my email along with Dr. Storm's in the chat in case anyone needs it. I think I do see a Q&A. Yes, this question says, will the slides be available? They will be. And actually, They have been approved, so I think I can go ahead and drop the link in the chat, but I will also be emailing the slides and the recording to everyone who registered here today later this week. If anyone else has a question, please put it in the chat. And in the meantime, I think I can get that link to the slide deck that we just looked at, and then you can access those resources. Here we go. Okay, so that is now in the chat if you would like to click that link to download the slides. But again, I will also be emailing it later this week. Take another moment here.
And if anyone wants to ask a question offline about anything, approaching their medical director, or dealing with any providers in the facility, feel free to email me directly, and I'd be happy to answer your question.
Okay, it looks like we have no further questions for today, so I will go ahead and wrap this up. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Dr. Storm, thank you for joining us again today and for this great and informative presentation. And we'd like to thank all of you for joining us again today, and we hope to see you back here again next week.